Good evening, sir. Good evening, all the students present here. Aspirants, we'll be starting with the session. The topic is neurological disorder, and the speaker that we have here is Dr. Varun Pushkarna, sir. He is a senior consultant at internal medicine at Fortis Escortis Hospital, Amritsar. So you can start the class. Thank you.
Okay, good evening. Thank you, Sana. Good evening, everyone. So, we will be starting with the neurosciences for EDIC part 1. So, we will be staying on the focus and not venturing into unrequired material. So, we'll be just focusing on what is the most important. So, that is clinical decision making. And in neurosciences, you will have a mix of neuromedicine and neurosurgical sciences. So let's begin with the one of the most and very important topic, aneurysmal bleed. So a 46-year-old woman. So we will do it in a vignette way because that is how it is going to come in the exam. Theory you all have read. I will only tell you how we will implement the theory in the how while we are attempting the questions. So a 46-year-old woman, she is admitted to the ICU after being found unresponsive at home. CT scan of the head reveals a large aneurysmal SAH with intraventricular extension and moderate hydrocephalus. She undergoes an EVD placement and remains intubated on ventilator. On day 5, the patient is noted by the nurse to be more drowsy and less responsive. The blood pressure is 160 by 90. Heart rate is 98. The temperature is 37.2 degrees centigrade and pupils are equal and reactive. There are no focal deficit which are new to the patient. Transcranial Doppler is ordered, which shows a mean middle cerebral artery velocity of 190 centimeter per second with a baseline of 120. What is the most appropriate next step in the management? So I'll leave the house open with this question. So can anybody tell me what is happening here? What is the problem here? If you can diagnose the problem, only then you can decide on the next plan of action.
Vasospasm.
Okay, that's a learned behavior, that's a learned answer. Anything else that you can think of in the given scenario? So she has an external ventricular drain. She is more drowsy and less responsive. The pupils are equal and reactive with no new focal deficits. Then why do we think it is a vasospasm?
Blocked EVD.
Wonderful. Who said that? So basically, what we have here is a EVD which is blocked. So what will we do? Administer IV mannitol and hyperventilate briefly. Number 2, administer nimodipine and increase the mean arterial pressure. That is called an induced hypertension. Give dexamethasone to reduce cerebral edema. Increase sedation and continue monitoring. Perform an urgent repeat CT to rule out rebleed. So as of now, we have two provisional diagnoses. One is a blocked EVD, which looks more likely the answer. Second is vasospasm. So what are we going to do next in the management? Yes, you have the answers in front of you.
Repeat CT.
So we have two answers. So the answer is administer nimodipine. So administer nimodipine and mean arterial pressure, that is induced hypertension. Okay. All right. So there were two answers and both of them, they appeared good. The elevated MCA velocity takes the answer. I wanted to give you a different situation so as to confuse you and you actually took another route. But you have to be very confident when you see such questions. Identifying the problem is important. Day 5 after aneurysmal SAH, new decreased responsiveness. What if there is no new deficit? The major component that you pick up is elevated MCA velocity. The baseline was 120 and now we have a 190 centimeter per second. So cerebral vasospasm, this is the time when actually cerebral vasospasm happens. And typically around, within the first week after SAH, peaking at 5 to 10 days. So the TCD velocities of more than 120 to 200, they are confirmatory for vasospasm. So when I was confusing you, you should have stood up and said, no, the mean velocity has increased. It has gone from 120 to 190. Definitely there is vasospasm, even if there is no issue as far as the neurological deficit or pupillary reaction is concerned. So how do we approach vasospasm? Initially, it was triple H therapy, that was hypertension, hypervolemia, and hemodilution, out of which hypertension is the most commonly used technique these days, and euvolemia being practiced more than hypervolemia, and hemodilution nowadays it is largely available to prevent vasospasm from happening. So we have to understand that there are two ways of handling a situation. One is not to let it happen. Second is, if it has happened, identify it and then take a corrective action. So we identified this case as, okay, two potential problems. One was blocked EVD. Second was vasospasm. So we prevent the vasospasm from happening by using nimodipine infusions. So we give them, it's a calcium channel blocker, and it is a general and a common knowledge to all the intensivists who practice that nimodipine is given. Now, therapeutic is when we treat a vasospasm. So it is triple H therapy as a bundle is no longer used, but it has a historical significance to it. So we will always be discussing it. Hypertension is mainly the one that we still bank upon, along with hypervolemia and hemodilution on case-to-case basis. What we are trying to achieve here is basically to increase the cerebral perfusion pressure through induced hypertension once the aneurysm is secured. So why the other options are not correct? Mannitol and hyperventilation could have been correct if there was a raised ICP, but the pupils, they are going against a proof of raised ICP. So there is no elevated intracranial pressure. The pupils are equal and reacting. Hydrocephalus is already drained, so we do not need mannitol. Although if it was an EVD issue, then we could have started with this and then eventually moved on to either redo the EVD or removing it. Steroids have no role in SAH-induced vasospasm. Mainly it is used in brain tumors, abscesses, where there is a space-occupying lesion leading to edema. Increasing sedation would worsen the assessment of neurological status and does not address vasospasm. So whatever we are going to do with sedation is not indicated as far as a vasospasm is concerned. A repeat CT, yes, but immediately what you have to do is give them nimodipine and increase the cerebral perfusion pressure. So you can always get a repeat CT done to check a rebleed, but with a late presentation, day 5, usually rebleeds don't occur, and with normal pupils, it's literally out of question. Okay, so and then. So we have to understand that SAH leading to vasospasm or vasospasm after SAH, the timing is within first to 2 weeks, peaking at 5 to 10 days. Diagnostic is TCD velocities. So I might throw as much as red herrings as possible. Either you can diagnose it with TCD, where the velocity is 120 to 200, and that is a catch point. Unless you know it, you will miss it in the exam just now as we did. And a MR angiography or CT angiography or a DSA scan. That DSA is basically done under angiogram in the cath lab. Treatment is nimodipine plus induced hypertension. Rest of the two H's, that is hypervolemia and hemodilution, are no longer accepted. The goal for everything is to maintain a cerebral perfusion pressure and preventing the delayed cerebral ischemia. So, hygiene points for any SAH is: number one, secure the aneurysm first, either by an open clipping or by a minimally invasive coiling before inducing hypertension, because that would only lead to increase in the bleed. After that, you give nimodipine to all SAH patients, but as a prophylaxis, that is preventable therapy. Once it has happened, then you will treat it with hypertension, induced hypertension. Is there any complication? Yes. Hyponatremia due to SIADH, due to pressure on the hypothalamus, and cerebral salt wasting is common post SAH. Is that clear how we approach this question?
If the question, if in the answer, if was a blocked EVD was an option as well, so how we would be approaching the question? It would be based on velocity again.
Yeah. So if the patient has a blocked EVD, all right, then what are the steps? Then immediately what we have to do is, it is basically a kind of hydrocephalus management, isn't it?
Yeah.
Yeah. So we will do everything in the same manner as is done in acute hydrocephalus. That is, we would jump in with immediately giving them mannitol, diuretics, and then calling the surgeon to either redo it or remove it, because many times all you have to do is remove the EVD, and because of that compression, the EVD blockage, the what do you say, the hydrocephalus is increasing. So we usually have to do it, but then it is the presentation will be with neurological deterioration one. There will be headache, the patient will start having vomitings, and you will start seeing neurological deficits depending on the site where the EDH was placed. Others are elevated signs of ICP. For example, bradycardia will be there, hypertension will be there. The patient may have a respiratory issue. So immediately, what you need to do is, whenever you come across a patient of a blocked ECG, what you do is do a non-contrast CT head, and at the same time give the patient some amount of mannitol or something like that. What are we looking for is midline shift and mass effect. That is what we are going to get, nothing else, because EVD was primarily put to drain the CSF, because the natural systems are not doing it. So immediately, whenever EDH, this EVD gets blocked, you have to either place another one, or have to put, I mean, you just remove that one and put another one, that is a surgical thing. But then you have to get rid of the blocked EVD and immediately give hyperosmolar therapy in the form of mannitol or 3% saline. And once you have and sometimes what you can do as an intensivist, if you know the marks, you can put in a needle and do a evacuation from the third ventricle. That you can do. That is called EDH evacuation. Or if somebody who is fast enough, they can change the EVD. Is that it?
Yeah.
So the important question in such a situation is, would we do or perform a lumbar puncture? Sometimes, once I had a situation actually when an EVD was blocked, and my resident said, "Ki, sir, why can't we decrease the pressure by doing a lumbar puncture and taking some CSF out?" What do you think? What will lumbar puncture do in such a situation? For a normal pressure hydrocephalus, many times we get a request to drain some CSF. But what is happening here is, there is a blockage upwards. So whenever you do a CSF drainage procedure in a patient of blocked EVD, it will only lead to a faster herniation and faster death, because the communication is blocked upstairs. So that is why EVD was put. Now that EVD is blocked, what is going to happen is the moment you are going to take out some CSF from the lumbar area, the patient is going to cone, and coning will lead to immediate death. Is that clear? I think I do have a question on EVD blockage also, so we'll come across that. So never ever do a lumbar drain in case of a blocked EVD. Is that okay? Yes?
Yes.
All right. So we move on to a next question. So we'll is this method okay, or you want a textbook kind of a situation? Yes? Is this fine? So next question, a 56-year-old man is admitted after being found unresponsive at home. CT shows a massive right basal ganglia intracerebral hemorrhage with extension into the ventricle and mild midline shift. His GCS is 7 E2 V2 M3. Because of his poor GCS, he is intubated, mechanically ventilated, and initial uh, management is head elevation. Blood pressure was controlled with nicardipine to target a systolic blood pressure of 140 and IV hypertonic saline for an intracranial raised pressure. Over the next 24 hours, this patient becomes bradycardiac. His heart rate is 42, blood pressure rises to 210 by 110. Pupils are unequal, and the right pupil is dilated and not reacting. The patient is ventilated in a controlled mode. So, ABG shows a pH of 7.37, PaCO2 of 32, PaO2 of 108, bicarbs of 19. So, which of the following is the best next step in the management of this patient? So, what is the diagnosis? First things first, what is the diagnosis? Quickly, we don't have that much of time. What is the diagnosis here? If you want to read the question again, I can give it to you.
Whether it has here ray blood,
Say again.
probably has ray blood again, and with
Yes. So what do we have here is, we have a patient who is coning, a patient who is going to have herniation. Why? What is this known as? Bradycardia, hypertension.
flesh.
Reflex.
Very good. So bradycardia, hypertension, and irregular respiration. We can't obviously see irregular respiration, but at least two things are there, and we have a Cushing's triad being fulfilled here. Okay. So this patient is going to cone very fast because there is intracranial hypertension and there is going to be a brainstem compression herniation if we do not intervene fast enough. So we would like to decompress the patient immediately. Number one, by hypertonic methods, and then going for a emergency decompressive craniectomy. This question, I don't know, has appeared in the exam so many times, and every time they are challenging a candidate's knowledge for management of acute ICP elevation secondary to a hemorrhage. The other options are increasing minute ventilation to target a PCO2 of 25, giving IV labetalol to reduce the blood pressure, starting high dose corticosteroids, or starting barbiturate coma. So the answer is decompressing the patient initially by IV mannitol and then arranging for an emergent decompressive craniectomy. So the patient with a large basal ganglia hemorrhage is now developing a Cushing's triad, bradycardia, hypertension, though he is ventilated. The new unilateral fixed dilated pupil is suggesting herniation due to increased ICP and impending brainstem compression. So our immediate goal is to reduce the ICP and prevent whatever brain is healthy to get injured. Immediately, what you do is you give IV mannitol or hypertonic saline. They are the fastest temporary measures to reduce ICP. Definitive management will always remain surgical decompression or evacuation of the hematoma if possible. Hyperventilating the patient causes cerebral vasoconstriction, yes, and causes a transient ICP reduction, and it is temporary. In fact, it can reduce cerebral perfusion on a longer basis, leading to worsening of ischemia. Extreme hypocapnia is dangerous. I mean, bringing the CO2 levels to below 25, it is very dangerous. Labetalol, okay, if it was a case of pure hemorrhage, then it would have been a good decision. But eventually, what we want is a blood pressure 140 systolic blood pressure. Less than 120 is only going to worsen the cerebral perfusion. So the numbers are very important. Steroids, they are ineffective and in fact harmful in case of ICH. As far as barbiturate coma, you can consider only in refractory ICP elevation after you've done everything else. For example, you've given 3% saline, you've given mannitol, you've done decompression, everything has failed. Now you can start the patient on barbiturate coma so that the brain doesn't need any oxygen. Important points to note here are that the patient will die of uncal herniation. You just need to avoid that. You just need to not let it happen. And uncal herniation causes ipsilateral third nerve palsy, that is oculomotor. It will lead to dilated pupil and contralateral hemiparesis. You need to remember the Cushing's reflex, that is, it is a late sign of ICP, bradycardia, hypertension, and irregular respiration. It needs immediate intervention. Osmotic therapy and decompression are life-saving bridge therapies. Eventually, the patient will recover from the healthier brain and settling of edema. But as of the situation, the patient needs emergent decompression. Steroids are contraindicated in spontaneous intracerebral hemorrhage. So, what are the targets of BP in ICH? They are a systolic BP of around 140. Okay, and a CO2 levels of around 35. So we don't go below 25 in any case. All right. Now let's move on to the third question. A 68-year-old man with hypertension, diabetes, atrial fibrillation is brought to the emergency department with sudden onset left-sided weakness and dysarthria for past 2 hours. On arrival, blood pressure is 184 by 96, heart rate is 88, it is irregularly irregular atrial fibrillation. NIHSS score is 15, CT head doesn't show any hemorrhage. CT angiogram does show the M1 branch of MCA right side occluded. Last dose of apixaban was taken 5 hours back. He's taken to neuro ICU and neurology recommends mechanical thrombectomy. After successful reperfusion, 6 hours later, his neurological status deteriorates. He becomes drowsy with right gaze deviation and vomiting. Blood pressure is 190 by 104. Heart rate is 58. CT head is done again and it shows a massive right MCA infarction with 9 mm midline shift. So, what is the most appropriate next step in the management? Is it IV mannitol and observing for neurological improvement, or starting hypothermia, or emergency decompression, or starting high dose steroids, or bringing the blood pressure down to less than 140?
Arrange for emergency decompressive craniotomy.
Great. So, what is the diagnosis here? One word.
Gentleman has raised ICP because of
So this is a malignant stroke. It is a malignant infarct. Means if you don't act fast, the patient is going to herniate and die. It's a life-threatening emergency. The answer is correct. You will have to go for an emergency decompressive hemicraniotomy or craniectomy. This patient has developed a malignant MCA infarction, and whatever you are going to do is not going to help unless it is a decompressive craniotomy. It will cause massive cytotoxic edema leading to midline shift and herniation. Medical measures like mannitol, hypertonic saline, they are only temporary. The definitive management is early decompression, ideally within 48 hours before brainstem herniation occurs and the patient becomes irreversible. IV mannitol, again temporizing. Hypothermia, it has not shown to improve outcomes in malignant stroke. It is mainly used after cardiac arrest and a successful CPR, which is a long CPR. Steroids have no role in cytotoxic edema, may worsen the outcomes. Aggressive blood pressure reduction can decrease. In case of ischemic stroke, the blood pressure is allowed up to 220 by 120 unless the patient is going for thrombolysis, for which the blood pressure target is, yes, if the patient is going for thrombolysis in a ischemic stroke, what is the blood pressure target?
180.
180, correct. So if you are not thrombolizing, then 220 by 120 is just fine. All right. Yeah, I'll be back in 5 minutes. In the meanwhile, you just read the clinical pearls for this patient. Okay. So the carry home points are that decompressive hemicraniotomy is essential. It has to be done within 48 hours to reduce mortality. Up to 50% absolute reduction is there, especially in patients who are younger than 60 years. Apixaban precludes IV thrombolysis. That is very important. The patient had taken the last dose of apixaban 5 hours prior. So, but it does not contraindicate mechanical thrombectomy. Remember, this is a red herring which you can find in the exam that patient was on apixaban or any other anticoagulant. Early recognition of neurological worsening post-reperfusion is crucial. It can indicate malignant edema or hemorrhagic transformation. Once one of my residents asked why the patient has a stroke if the patient was on apixaban. Now these medicines, they are only meant to prevent a possible embolic stroke. That doesn't mean that it will prevent. So there is always there is a percentage of patients who will still have such a notorious situation that they will still have a stroke, an ischemic stroke, even on anticoagulants. All right. Is that clear? Okay. So next question, a 42-year-old woman with history of lupus nephritis, patient on mycophenolate and low-dose prednisolone, is admitted after a generalized tonic-clonic seizure that lasted 15 minutes. She was given lorazepam 4 mg IV followed by levetiracetam 60 mg per kg IV loading, but the seizures persisted. On arrival to neuro ICU, the blood pressure is 152 by 88, heart rate is 118, saturation is 94, temperature is 37.8. She is in coma but still having rhythmical facial and limb jerks. Labs, sodium is normal, glucose is 118, creat is 1.2, CT head is normal, continuous EEG shows ongoing generalized epileptiform activity. Third drug is decided to be given and IV valproate 40 mg loading is done, but the seizures are still persisting for more than 60 minutes. What is the diagnosis? What is the diagnosis?
Toxicity of mycophenolate.
Okay, that is a secondary diagnosis. What is the primary diagnosis? This patient has a refractory status epilepticus. This patient has a refractory status epilepticus. Why refractory? Because the patient has already been given 3 anti-epileptic drugs, and patient still has seizures for last more than 60 minutes. Okay, we have all the time in the world to define what is the secondary reason for the status epilepticus. But recognizing it in time and treating it as a war footing, it is important before the brain burns itself out. So, what is the most appropriate next step in the management of this patient? So, the diagnosis is refractory status epilepticus. It's not a simple status epilepticus, it is refractory status epilepticus. Which of the following is most appropriate? Next step, give additional benzodiazepine bolus and continue observing. Begin continuous midazolam infusion. Titrate it to a burst suppression on EEG. Start phenytoin infusion at 20 mg per kg. Give IV magnesium sulfate 4 gram bolus. Proceed to urgent plasmapheresis for a possible lupus cerebritis. So, what is the next best step? It's okay, you have to pick one. That's all. What would that be?
Proceed to urgent plasmapheresis for possible lupus cerebritis.
Okay, so how are we going to treat the status epilepticus that's happening here? Because plasmapheresis एकदम से शुरू नहीं होगा. We'll have to add on something which
But we need to
breaks.
give
Yeah,
benzodiazepine.
yes. So we have to give the patient some medicine which can induce coma in this patient, either a continuous midazolam infusion or phenobarbital infusion. So the choice of answer is dependent on the outcome that you wish to get. The problem here is status epilepticus, which is refractory. The solution here is turning it to a straight line. So that has to be done immediately. For a heart, we know if the patient has a ventricular tachycardia, it is refractory, you give shock. But in brain, you just have to stick to medicines. So we begin continuous midazolam infusion to titrate it to a burst suppression on the EEG. So the patient has a refractory status epilepticus. Seizures have been persisting since last 60 minutes despite first line, second line therapy. At this stage, a coma induction is the treatment of choice to suppress the cortical activity and prevent excitotoxic neuronal injury. How do we manage status epilepticus? So, phase initial 0 to 5 minutes, we try to stabilize the airway, we manage the glucose and electrolytes, we give lorazepam IV, maximum 4 milligram. Repeat once if needed. Second is established phase. That means now the status epileptic has established itself. It's within 5 to 30 minutes. Add a long acting anti seizure medication, for example, levetiracetam, 60 mg per kg, or valproate 40, or phosphenidoin. Choose one drug, not multiple simultaneously, because you will not know which drug has helped. Then there is a refractory phase when it has gone beyond 30 minutes to 60. No response to any of the medications. Now the treatment would be to induce an anesthetic coma, either by midazolam, propofol, or pentobarbital. What is the target to treat? The target is to treat with EEG burst suppression. Now there comes another terminology which is called super refractory status epilepticus, which is when you've already utilized three or more drugs and the seizure has persisted beyond 24 hours. So whenever you try to taper the medicine, the patient again has a burst of seizure. What are the drugs that can be given at that time? Ketamine is one drug which can be given. Then there are hypothermia can be induced, or immunotherapy can be given, or visual nerve stimulation can be done, or surgical options are there to remove. Why other options are incorrect? Additional benzodiazepine, we've already given 4 milligram of lorazepam. So already maximum dose has been given. Now we have to definitely act and do a straight line for the patient's EEG. Phenytoin is another second line agent. Remember, we have come beyond that. We is beyond 60 minutes now. So failure of two adequate agents to control the seizure defines refractory status epilepticus. Repeating same tier of drugs is not going to help. So we will need to induce anesthetic coma here. Magnesium sulfate is indicated only in eclampsia-induced seizures. Then is plasmapheresis. Fine, once you have treated the status epilepticus, now there is a time that you start plasmapheresis to take out any autoantibodies if you have to remove. Is that clear for this question? This is very important. I've selected the most important golden topics for your exam. So key ICU principles are: number one is airway protection. Second is EEG monitoring, which is a continuous one. We need to see it if you are treating a patient of refractory status epilepticus. It is a mandatory thing. Then is hemodynamic support using all these drugs, which are, these sedatives, anti-epileptic drugs, they can cause hemodynamic instability. So you might require vasopressors as and when needed. Yes, you need to investigate the underlying cause, but that doesn't happen immediately. Metabolic, structural, infectious, autoimmune, toxic, or withdrawal kind of seizures can be there. Then go for a step down. After 24 hours have been seizure free, how you would know that? You would know that only through a continuous EEG monitoring. Once you have a 24-hour seizure free period, then you taper the anesthetic drug but continue the anti-seizure medications. So step 1, step 2, step 3, step 4. Step 1 is basically initial. Second is established status epilepticus. Third is refractory status epilepticus. Fourth is super refractory. All the drugs are different. You need to study about them. Midazolam can be started with a bolus of 0.2 milligram per kg. For a 60 kg man, 12 milligram bolus is fine. And 0.05 to 2 milligram per kg per hour infusion needs to be given. Rapid onset and easily titrable. You stop it, the context sensitive half-life is less, so it is good. Propofol is a bit effective alternative, but you need to check for propofol infusion syndrome, pancreatitis, hypertriglyceridemia, cerebral edema and all. Pentobarbital is used for super refractory cases. It requires vasopressors, mechanical ventilation, and continuous EEG monitoring is mandatory if you are starting the patient on pentobarbital. If it is an autoimmune kind of a refractory status epilepticus, then yes, immunotherapy, for example, methylpred or IVIG or rituximab may be required, but after seizure control. That is, even if it is a cerebritis, you do it after controlling the seizures. Is that okay? Clear? So your intervention has to be based on the diagnosis. The diagnosis is refractory status epilepticus, treat it as it is. Okay? Next question. A 27-year-old man is brought to emergency department after a high-speed motorcycle collision. He was wearing a helmet but was found unresponsive at the scene. GCS is low, 6 E1 V1 M4. Pupils right is 5 mm sluggish, left side is small 3 mm but reactive. BP is 150 by 90, heart rate is 52, saturation is 95% on oxygen. He is immediately intubated and mechanically ventilated. CT head is done, which shows a large right temporal contusion with a midline shift of 6 mm and effacement of basal cisterns. So he is admitted to the neuro ICU. ICP monitoring is done, which shows an ICP of 32. What is the normal ICP? What is the normal ICP?
5 to 22 mm.
So anything above 22 is ICP elevated. So patient has ICP of 32, so that means the patient has intracranial hypertension. PaCO2 is 36, PaO2 is 98, mean arterial pressure is 85. The neurosurgery team plans evacuation of the contusion but ask you to stabilize the ICP first. So what will you do? Induce hyperventilation to achieve a PSU2 of 25, give 3% hypertonic saline 250 ml over 10 minutes, start high dose corticosteroids to reduce vasogenic edema, lower the patient's mean arterial pressure to reduce cerebral perfusion pressure, or administer IV mannitol 0.25 gram per kg and keep head flat. So, what is your answer? How will you reduce and stabilize the ICP in this patient? So, what are the first steps? First step to reduce ICP is using hypertonic or osmotic diuresis. So once you've done that, then the patient goes for a definitive treatment. Okay. So the answer is administer hypertonic saline 250 ml over 10 minutes. This patient has a severe traumatic brain injury with intracranial hypertension, ICP more than 22, and clinical radiological signs of mass effect, that is midline shift with Cushing's triad, that is bradycardia, hypertension, labored breathing. Immediate goal is rapid osmotherapy to reduce brain volume and prevent herniation before surgical evacuation takes place. Mannitol and hypertonic saline are both used for ICP control, but hypertonic saline therapy is increasingly favored in modern neurocritical care for its more stable hemodynamic profile and efficacy in maintaining intravascular volume. So, what is the management of raised ICP in traumatic brain injury? So, number one is tier one. Basic is elevate the head by 30 degree. So, keeping the head flat is itself a very wrong answer. Elevate the head end by 30 degree. Keep neck midline, very important. Maintain a PSU2 of 35 to 40, very, very important. Avoid any hypotension to target a CPP, cerebral perfusion pressure of more than 60. Control any fever, pain, and agitation. Non invasive management is the first line. Then you move up the ladder, tier 2, where hyperosmolar therapy using mannitol 0.25 to 1 gram per kg IV bolus or 3% saline 250 ml over 10 to 15 minutes. Of course, propofol is important to induce a cerebral coma. Short-term hyperventilation to target PSU2 of 30 to 35 is fine, but it is an extremely temporizing measure until surgical decompression is done. Tier 3, that is refractory ICP. Nothing is working, so you induce a barbiturate coma. You don't want brain to utilize any oxygen. Then you use hypothermia selectively, specifically after a cardiac arrest happening in event of a roadside accident. Then immediately perform a decompressive craniotomy if the ICP is more than 25 and not responding to any other measures. Why the other options are incorrect? Hyperventilating the patient to a PSU2 of 25 is causes rapid vasoconstriction and transient ICP drop but risks cerebral ischemia. So you can only use it for 30, 40, 50, maybe 2 hours, minutes to 2 hours. Corticosteroids are contraindicated in TBI. They can increase mortality. It was shown by the crash trial. Lowering the mean arterial pressure can be dangerous. Do not do that. Whenever you are using propofol, be very, very cautious that it does not decrease blood pressure. Remember, the definition of CPP is basically equation shows mean arterial pressure minus ICP. That means you cannot function if you do not have an ICP monitor in place. Mannitol plus head flat. See, mannitol is fine, but head flat is not fine. You have to elevate it to minimum 30 degrees to facilitate venous drainage. And as I've told you, mannitol, the dose will be 0.25 to 1 gram per kg body weight on the higher side. And nowadays, as I've told you, it is hypertonic saline, which is preferred because of its hemodynamic instability and equivalent efficacy. So let's review our targets. ICP has to be less than 22. Cerebral perfusion pressure has to be between 60 to 70. Partial pressure of carbon dioxide has to be 35 to 40. PA oxygen has to be more than 100. Sodium 145 to 155. So remember that this question has also been asked many times. So this is the target of the patient is on hypertonic saline. Okay. What are and normothermia? What are the clinical pearls from this question? One, again, Cushing's triad, hypertension, bradycardia, irregular respiration are a important but late sign of raised ICP. Hypertonic saline rapidly expands plasma volume and draws the water from brain parenchyma. Monitoring sodium and osmolarity. Mannitol may cause hypovolemia and hypotension. Avoid if the systolic blood pressure is less than 100 or renal dysfunction is present. Definitive treatment is decompression once stabilized. All right, next question. A 58-year-old woman with history of hypertension, sudden severe headache, vomiting, and rapidly decreasing consciousness comes to the emergency department with a GCS of 7, blood pressure of 176 by 94, heart rate of 52, respiration of 10, and pupils equal and reactive. CT head shows a diffuse intraventricular hemorrhage with moderate hydrocephalus, dilatation of lateral and third ventricles, effaced fourth ventricle. There is no large intraparenchymal clot or any midline shift. She is intubated. She is transferred to neuro ICU. Neurosurgeon places an external ventricular drain in the right frontal horn of CSF diversion. So everything is done. Over the next 2 hours, patient ICP remains around 30. She continues to be poorly responsive. The nurse reports no CSF drainage from the EVD despite a pressure gradient of 15. Now, what is the next most appropriate next step? So we have a patient who has a blocked EVD. So increase the EVD drainage height to 25 centimeters, lower the EVD drainage system to 0, administer IV mannitol to reduce ICP, check for any blockage and ensure catheter patency before adjusting height, clamp the EVD and start hyperventilating. So the correct answer, it is check for EVD blockage because it is not draining and the ICP is elevated. So there is a sufficient pressure gradient, but EVD is not draining. The most likely cause is catheter blockage, typically by a blood clot or debris, especially in case of an intraventricular hemorrhage. Okay. Before altering drainage height or initiating any osmotherapy, you must confirm EVD patency since an obstructed catheter nullifies any drainage adjustment. How to approach a EVD troubleshooting? Very important. Number one, check connections and stopcocks. Ensure proper alignment towards the drainage chamber. Then aspirate gently, less than 1 ml, under sterile conditions. Remove any clot or debris blocking the catheter tip. Then confirm a fluid level with no kinks or tension in the tubing. Avoid any mechanical obstruction, that means kinks. Reassess ICP waveform. Return of pulsatility suggests restoring patency. If the obstruction persists, then either do a CT head to assess the catheter position or ask the surgeon to replace the external ventricular drain. Increasing the height of the drainage will not help. Raising the system reduces drainage because it will go up. So the gradient reverses. Lowering it to 0 centimeter may cause siphoning and dangerous over drainage. Now that is a problem. Even if you are using a syringe, it has to be done very slow. Immediate aspiration may lead to subdural hematoma. Mannitol is a temporizing measure, will not correct the mechanical cause. Clamping and hyperventilating. Hyperventilation is the last resort. Clamping of an obstructed EVD, it is only going to worsen the situation. So what are the key concepts? Number one, EVD leveling, zeroed at foramen of Monro. Very important. External auditory meatus or tragus. So external ventricular drain has to be zeroed at foramen of Monro. The drainage height has typically to be set at 10 to 15 centimeter of water above tragus. This controls how much CSF will be drained. Over drainage risk, subdural collections, collapsed ventricles, herniation. Under drainage risks, refractory raised ICP, worsening hydrocephalus, sterile handling. Every disconnection increases the risk of meningitis. So follow very strict asepsis. Goal of ICP control is less than 22. Goal of CPP maintenance is more than 60 to 75. Obstruction is the most common cause of failed EVD drainage in IVH patients. If frequent blockage occurs, consider intraventricular thrombolysis with alteplase. Now, this is very important. Clear 3 trial has shown to accelerate clot clearance and it is indicated. That means don't think that it is already a case of intracerebral hemorrhage. So, why are we going to give it? So, that is an indicator thing. Alteplase 1 mg, 6 hours. Are we clear till now? If nobody says, I think uh, I didn't get to know
The
who
only
is the, yeah.
is proof.
Next question again is an important one. Brain death. A 35-year-old man is admitted to neuro ICU after a high-speed road traffic accident. Initial CT brain shows a massive subdural hematoma with herniation. He undergoes emergency craniectomy and evacuation, but postoperatively remains comatose after 48 hours. GCS is E1 M1 VT. Pupils are fixed, dilated bilaterally, absent corneal cuff and gag reflexes. No spontaneous respiration when ventilator set is support, minimal support. Vital signs map is 80 on low dose norepinephrine. Temperature is 36.5. Saturation is 99. EEG shows EEG shows electrocerebral silence, and CT shows angiography shows no intracranial blood flow. Now, the attending physician plans to perform a brain death examination. Which of the following must be confirmed before performing the brain death examination? So, something is very clear that you cannot initiate the brain death assessment if the patient is on sedative drugs. So very, very clear, the patient cannot be on any sedation. So presence of intact spinal reflexes has to be confirmed. Administration of sedative reversal agents has to be confirmed. It is very, 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 very important. The patient cannot be on sedative reversal agents. The rest, everything you can, give it a miss. But if the patient is on sedative reversal agents, you have to just uh, confirm that it is not going. Before the brain death examination, it is essential to remove all the confounders that can mimic brain death, specifically residual sedatives, neuromuscular blockers, metabolic derangements, or hypothermia. So, what is this framework for determination of brain death? So, prerequisites before examination are number one, all must be satisfied in this criteria. Established cause of coma, known catastrophic brain injury, irreversible condition, excluding any intoxication, shock, metabolic or endocrine coma, no CNS depressants, sedatives, barbiturates, opioids, alcohol, reversal agents, flumazenil may be used if indicated. No neuromuscular blockade should have been going. Confirm with trainer for monitoring. Core temperature has to be more than 36 or equal to 36 degrees. Systolic BP has to be more than 100. Then clinical examination is brain stem reflex, pupillary. There is no reaction to bright light bilaterally. Corneal reflex should be absent to cotton swab. Oculocephalic reflex, that is doll's eye reflex. There should be no eye movement with head rotation. Oculovestibular, that is cold caloric test. No eye deviation with ice water. Gag or cough, absent on tracheal suction. Facial or pain response, no grimacing or movement should be there. Motor response should be none, except spinal reflexes, which may persist. We are not concerned about them. So these are very important clinical examinations. Then is apnea test. What is the purpose? The purpose is to confirm absence of spontaneous respiration despite the hypercapnic stimulus. So what we do is we pre-oxygenate the patient to a PaO2 levels of more than 200. Then we disconnect the ventilator. We keep providing oxygen via nasal cannula in the endotracheal tube. Then we look for the respiratory effort for good 8 to 10 minutes. The test, if positive, supports brain death if number one, there is no respiratory movement, or the carbon dioxide rises to above 60 millimeters of mercury, or above 20 millimeters of mercury above the baseline test, and the patient has no respiratory movement. That means respiration could not be triggered by elevating carbon dioxide. If the patient becomes unstable, for example, patient that develops an atrial fibrillation or a ventricular arrhythmia, immediately terminate the test and then use some other test. What are those other tests? Number one, you can do an EEG. EEG will show you an electrocerebral silence, that is straight line. Or you can do a CT angiogram or a MR angiogram or a DSA, which will tell you absent intracranial blood flow. Or you can do a transcranial Doppler again, which will show no diastolic or reverberating flow. Then, of course, if you still want to confirm, then SPECT or nuclear scan, which shows a hollow skull sign. That is, there is no uptake of the nuclear marker or the SPECT material by the brain. So there is absent cerebral uptake. Ancillary tests, they are not required if full clinical and apnea tests are completed successfully. They are only indicated if the patient becomes hemodynamically unstable or develops some arrhythmia. Okay, before closing this question, let's look at the other options. Intact spinal reflexes do not preclude brain death. Movements such as triple flexion, Lazarus sign, these are spinal reflexes, they may still persist. Temperature less than 35, hypothermia invalidates testing. You need to have temperature more than or equal to 36. PSU2 more than 40, this is before starting apnea test. It must rise to more than 60 mm or more than 20 from the baseline. EEG silence, it is an ancillary test. It is not a prerequisite if full criteria can be assessed. So if the full criteria can be assessed, always go for apnea test and full criteria test. Other ancillary tests, they are not a essential ones, but if you cannot perform the primary test, only then you can go for them. Brain death is defined as an irreversible cessation of all the functions of entire brain, including brainstem. The diagnosis is purely clinical, imaging or EEG supportive when exam is incomplete. Two examinations by two independent qualified physicians should be done. Organ donation should be discussed after determination of brain death, not before. Autonomic functions like heart beating, like respirate, like not respiration, but intestinal movements, they can still persist because respiration is a criteria to define brain alive. If respiration is absent, apnea test is positive, then it is brain death. Core criteria for brain death parameter, we know temperature should be more than 36. The known etiology should be known. It should be irreversible brain injury. Systolic BP should be more than 100. Sedative neuromuscular blockage should be excluded. Brainstem reflexes should be absent. Motor response, there should be no motor response except a spinal reflex. Apnea test should be positive. No breathing despite PSU2 of more than 60 or 20 mm above the baseline. Ancillary tests are usually not needed, but if needed, you should be able to prove a flatline ECG or no cerebral blood flow on CT angiogram, MR angiogram, DSA, digital subtraction angiogram, or negative SPECT scan. Okay. Next question is about targeted temperature management in post cardiac arrest coma, that is induced hypothermia. A 58-year-old man is admitted to the ICU after an out of hospital cardiac arrest due to ventricular fibrillation. He received 8 minutes of CPR before any ROSC. On arrival, his blood pressure is 110 by 70. Blood pressure on norepinephrine. SpO2 is on ventilator. 96% his pupils are equal and reactive. He withdraws to pain but does not follow any commands. Targeted temperature management is initiated at 34 degrees centigrade for 24 hours. On day 3, after rewarming and cessation of sedatives, the patient remains in coma. Pupils are 3 and reactive, corneal reflexes present, no motor response to pain. EEG shows generalized periodic discharges without reactivity. Serum NSC, that is no neuron specific enolase, is elevated to 92. Brain MRI shows diffused cortical and basal ganglia diffusion restriction. Which of the following is most appropriate next step in prognostication and family counseling? Number one, declare a poor neurological prognosis and recommend withdrawal of life support treatment. Repeat neurological assessment and multimodal prognostication after 72 hours of normothermia. Perform brain death assessment immediately. Start methylprednisone for possible post-hypoxic inflammation. Obtain a repeat EEG for reactivity. So, what is the next most appropriate step? It is to repeat neurological assessment after 72 hours of normothermia. Now that you've achieved normothermia, the patient is still in coma, don't lose heart. Wait for another 72 hours and then reassess. So, after cardiac arrest, prognostication should never occur before 72 hours after rewarming and discontinuation of sedation. You stopped the treatment today, you stopped the sedation today, you stop the hypothermia today, wait for next 3 days, then discuss about the outcome of patient. Hypothermia, sedatives, and metabolic derangements can confound clinical on 72 hours of return to normothermia. Not just RO, you have to clinical exam to assess reflex and motor response, EEG, and serum NSC of more than 6 images, dental and to absence. No single test is sufficient for prognostication. Brain death should only be considered if all brainstem reflexes are absent and apnea test is positive. Not the case here. The patient is still breathing and he is having some amount of motor component. So, what are the high yielding points here? Number one, TTM target is 32 to 36 degrees for 24 hours, followed by slow rewarming. Sedatives, neuromuscular blockers, hypothermia, metabolic causes, all are confounders. So try to see that they are not going on. Prognostic window should always be used after 72 hours of normothermia achievement. Reliable poor outcome predictors are bilateral absence of N2 and 20, absent pupillary corneal reflexes, and NSC of more than 60, which is not neuron specific enolase at 48 to 72 hours, and diffuse anoxic injury on MRI. Early withdrawal of care based on premature assessment is the pitfall. Sometimes patient may take longer period of time. We still have 3 more questions to go. Are we there?
Yeah.
So next question is about cerebral perfusion pressure. We know that it has to be more than 60 to 75. A 24-year-old male is brought to the emergency after a high-speed motorcycle accident. GCS is 6, BP is low, 85/40, heart rate is 126, saturation 94 on 100% oxygen. Pupils are unequal. Right side 6 mm. CT shows a large right temporal contusion with 7 mm midline shift. EVD is placed for ICP monitoring. Mean arterial pressure is 70, ICP is 28. PaO2 is 92, serum sodium 138, temperature 37. Despite sedation, the ICP remains persistently at 28 to 30. Which of the following is the most appropriate next step in optimizing cerebral perfusion pressure? Number one, starting mannitol. Number two, starting norepinephrine to target a CPP of more than 60. Number three, hyperventilating the patient with a PaCO2 of 25. Administering IV dexamethasone or increased propofol sedation to achieve burst suppression. So here it will be to maintain a blood pressure. that is starting norepinephrine. Initiating mannitol 0.5 gram per kg bolus could be a good thing, but I don't know if it is going to help for optimizing cerebral perfusion pressure. Hyperventilating to CO2 less than 25 is a wrong notion. We don't do that. Dexamethasone is contraindicated. Sedation to achieve burst suppression on EEG will only going to decrease the blood pressure. See, the patient's BP is already 80 by 50. So what are we going to achieve with propofol sedation is even further hypotension. So the patient needs a for cerebral perfusion pressure more than 60. But here the patient's MAP minus ICP, that is 70 minus 28 is 42, which is inadequate for cerebral perfusion pressure. So maintaining it is between 60 to 70 is the target. So we need to optimize brain oxygenation and minimize secondary brain injury. So how can we do that? We can do that by raising the mean arterial pressure by using vasopressors such as norepinephrine. If ICP remains high, that is 22, and so once you have started norepinephrine, then you start osmotherapy and elevation of head by 30 degrees. Brief hyperventilation can be done, but never below 35. Steroids have no role. Propofol can reduce ICP by targeting, but it will also cause hypotension. So primary is to bring the blood pressure up. So MAP minus ICP. We are not able to decrease ICP. Let's elevate the MAP. Let's bring the MAP to 90. So 90 minus 28 will be 62. So we have a pressure of 60 and above. So we are in the safe range. Key targets are ICP less than 22, CPP 60 to 70, MAP more than 80, and PaCO2 of 35 to 40, serum sodium of 145 to 155. So next question is management of Guillain-Barré syndrome. A 42-year-old man presents with 3 days of progressive weakness in both legs, now involving the arms. He reports difficulty in climbing the stairs and tingling in his fingertips. He had a self-limited diarrheal illness 2 weeks ago. BP is 118 by 72, heart rate is 104, respiratory rate is 18, SpO2 is 97. Reflexes are absent throughout. Power is 3 by 5 in both upper limbs, 2 by 5 in lower limbs. Sensation is intact to light touch. Cranial nerves are normal, lab studies are normal. CSF shows 160 protein, WBC count of 2, nerve conduction pending. Vital capacity is 18 ml per kg. Negative inspiratory force is 28. While in the ICU, patient develops sudden bradycardia and hypotension during suctioning. So what is the next best management step? So the patient has developed bradycardia while suctioning. What are we going to do? So are we going to intubate the patient and starting mechanical ventilation, or IV methylpred, or starting IVIG, or starting atropine, or starting plasma exchange? Right now, the patient has developed bradycardia. This patient has autonomic instability secondary to Guillain-Barré. So you will need to do urgent atropinization. This patient has Guillain-Barré, likely post-Campylobacter, now developing autonomic dysfunction, which is a hallmark of severe GBS requiring neurocritical care. Sudden bradycardia and hypotension during suctioning leads to vagus stimulation and hence needs atropine immediately because it can be life-threatening. Patient can develop a straight line. Indications for intubation are when the patient's vital capacity is less than 15 ml per kg. But here it was given that the vital capacity is 18. So it is still above 15. And negative inspiratory force has to be minus 28. It is good one. That is, the patient is able to generate a negative inspiratory force of minus 28. So whenever the patient develops a negative inspiratory force of less than 20, then is the time when they have to be intubated. Rapidly declining respiratory parameters, for example, rising CO2, dropping high oxygen, shallow breathing, use of accessory muscles, all of them will require intubation. Bulbar dysfunction, poor cough, gag, or swallowing. Then comes This patient's vital capacity is 18 and negative inspiratory force is minus 28, which is adequate for now, but will require hourly reassessment. As far as autonomic instability is concerned, common features like paroxysmal bradycardia, tachycardia, hypotension, arrhythmias, and cardiac arrest, all of them can happen. They usually are triggered by suctioning, pain, or movement. Treatment: atropine for bradycardia, norepinephrine for hypotension, and continuous ECG and BP monitoring in the ICU is important. Disease modifying therapy, there are only two therapies. One is IVIG, second is plasma exchange. Steroids are not beneficial. What are the high yield points in GBS? It is a rapidly ascending paralysis. So you will need to early ICU admission. If the vital capacity is less than 15 and a negative inspiratory force is less than 20, minus 20, the patient needs an intubation. If the patient has autonomic instability, the patient should be on continuous ECG and SOS atropine if it occurs due to vagus stimulation. First line treatment is IVIG or plasma exchange. Second line is combination of both IVIG and plasma exchange. Do not use steroids. Most common cause is Campylobacter jejuni gastroinfection. 85% will recover, 5% will have mortality. Clinical pearl is that in GBS, autonomic instability can cause sudden death even when muscle strength seems normal. So atropine has to be given immediately, and the patient has to be on a continuous monitoring in all ICU admitted Guillain-Barré syndrome. Next question is again on Guillain-Barré, but on a different note. A 42-year-old man presents to emergency department with progressive weakness over the last 4 days. He reports difficulty in climbing stairs. Everything else is basically a history of Guillain-Barré syndrome. Now the patient reports increasing breathlessness while lying flat. He is able to speak in full sentences. Saturation is 95, respiratory rate is 28, but heart rate is 110. Which of the following is most appropriate step in this patient? Number one, closely observe in the ward. Start non-invasive positive pressure ventilation immediately. Admit to ICU and perform elective endotracheal intubation if FVC is less than 20 ml. Start high-dose corticosteroids and monitor respiratory function. Perform emergency intubation immediately. So basically the criteria is FVC less than 15, not 20. So please check it. So what are we going to do? Clinical scenario: rapidly progressive weakness over 4 days, flaccid paralysis, absent reflexes, classic GBS, facial weakness, cranial nerve involvement, mild tachypnea, orthopnea, early respiratory compromise. GBS can cause rapid respiratory failure, so should never be managed in the room or ward. It has to be in the ICU. Close monitoring is important. Patient may need bradycardia-induced atropine, hypotension induced norepinephrine use, and respiratory collapse needing intubation. Why not B? Immediate non-invasive ventilation. Non-invasive ventilation is generally not recommended as primary support in the GBS with impending respiratory failure. So bulbar weakness and secretion retention can increase the risk of aspiration. So you do not put these patients on non-invasive. Why not steroids? Not effective. Why not emergency intubation? You have to be very, very clear because intubation will have its own problems. So if the patient has a good vital capacity above 15, then you above 20, you do not require it. So elective intubation is needed for all these factors. Monitoring for impending respiratory failure, FVC has to be done serially, negative inspiratory force. Ventilation strategy in GBS, patient has to be on assist control or pressure control ventilation, tidal volume 6 to 8 ml per kg. Avoid barotrauma, plateau pressure has to be below 30 centimeters, and weaning off should start when FVC improves. Give them a spontaneous breathing trial when the minimal secretions and they have a good bulbar function. Most patients would recover in 2 to 4 weeks, and everybody has their own individualized prognosis in case of GBS. That's all for today. So
Okay, sir.
thank you very much. Thank you very much for a patient listening. See
Thank
you
you.
next time.
If
Bye.
any aspirants have any question, they can write it on the chat box, please. So I believe there's no question. We'll be having another session though. So we'll be scheduling it soon. Thank you.
Thank you. Bye.